Good afternoon, it's Austin Docherty again, and I would like to demonstrate how I examine the lumbar spine. Assisted by my colleague here, we will just run through how I would normally examine a lumbar spine. The first thing that we would do in any examination is observation, and what we are looking for when we observe the patient is that they are symmetrical, that there appears to be no pelvic tilt, that there is no signs of any scoliosis. We look for, particularly an anterior pelvic tilt that may increase his lumbar lordosis. We look for a normal cervical lordosis, thoracic kyphosis, and as previously mentioned, an exaggerated lumbar lordosis may indicate an anterior pelvic tilt, which may increase his risk of low back pain. We would then assess his core stability, and to do this we would ask him to do a single leg squat, and if we could just ask you to do that. And we're looking for any movement, any internal rotation, abduction of his knee that may indicate that his core stability is weak. Following this, we would then move on and assess his movement. And the way that we assess movement is the main things that we're interested in are flexion, extension, lateral rotation, and lateral flexion. To assess flexion, we would ask the patient, if we can just get you to turn round, I'd like you to bend forward and touch your toes, please. And this assesses the amount of flexion that we get. We may find, if we noted a scoliosis on observation with him standing erect, if we get him to bend forward, if it's a structural scoliosis, the curvature would remain. If it's postural, it would tend to go on flexion. To measure flexion, we can do a thing called Schober's test. And Schober's test is a way of measuring the amount of flexion that we get at his lumbar spine. The way that we do Schober's test is that with the patient standing, we would identify the posterior iliac spines, and we would draw a line across from both posterior iliac spines and make a mark on his lumbar spine. We would then measure 5 centimeters below this mark and 10 centimeters above the mark. Following this, we would get the patient to flex again, and we would measure the distance between the two marks. An increase of over 5 centimeters would be considered normal when the patient flexes. Anything less than that would be considered abnormal and would indicate that there is a problem with flexion at his lumbar spine. The next thing that we would assess for would be extension. By stabilising the patient's pelvis, we'd ask him just to bend backwards towards me. Okay, that's fine, and if you could just straighten up. If we wanted to assess the patient's SI joints, we could do the Stoke test. And what we would do in this situation is we would get the patient to raise, to stand on the leg where the pain is, and just get him to bend backwards towards us. So can I just get you to lift your left leg up, and if you would bend backwards towards me? That's fine, and straighten up for me. A positive Stoke test would be that if that movement elicited pain, and that may indicate that there is a sacroiliac joint problem. Following on from that, we'd move on to lateral flexion, and again, stabilising the patient's pelvis, we'd ask him to just push this arm down your leg as far as you can. That's fine, and now the other side. That's fine, and straighten up for me. Okay, that's good. Next, we would test for rotation. Again, stabilising the pelvis, we get the patient to rotate to his left and to his right. And as we can see, we have a good range of movement there. The main movements concerned with your lumbar spine is more to do with flexion, and your thoracic spine is more linked with rotation. Following this, we would now like to see the patient walk, and again we're looking for symmetry, and we're looking that there's no antalgic gait. Could I just see you walk, please? And come back towards me. So the patient has a normal gait. If we were worried about an L5 or an S1 lesion, or problem, we can assess L5 by asking the patient to walk on his heels. Any weakness that we identify in heel walking may indicate an L5 lesion. Can we get you to walk on your heels, please? And if you turn around, and if you come back and walk on your toes. Tiptoeing, again, any weakness in tiptoeing may indicate an S1 problem, and obviously we may need to look at that. Next we would move on to palpation, and we would actually get the patient just to turn round. Palpation, we would look at the spine itself, so we would palpate the spine. We would also palpate the paraspinal muscles, which may indicate a lesion or a problem in that area. So if we get the patient just to straighten up, we would normally start at his cervical spine and we would work our way down, asking for any tenderness, for the patient to tell us if there are any tender points. Okay, then we would check on the paraspinal muscles, and again we elicit no tenderness. That's fine. So we've observed, we've seen some movements. Next we would move on to special tests that may indicate a lesion in his lumbar spine. The first test that I would like to demonstrate is the tripod test. The tripod test will tell us if we have any lesion in his lumbar spine, which may be a herniated lumbar disc, or it may indicate some neural tension that we have. We'll get the patient to sit on the couch, and I will go around to the patient's right hand side. What we are looking for here with the patient sitting in this position is we are going to extend his knee and we're going to observe if there are any pain. So I'm just going to straighten your leg. Okay, and there's no pain at all there as we do that, and there's no referred pain or radicular pain. A positive tripod sign would be that as we do that test, what happens is the patient will extend and will put both hands behind him, and hence it's called the tripod test. A similar test to that is one called the slump test, which again assesses similar parameters. The slump test, with the patient in the same position, we would get the patient, we would flex at the cervical spine, and we would repeat the process of extending out the knee, and again a positive test is if we produce any radicular pain. That's called the slump test. An extension of that may be to look for a problem with his obturator nerve, and the slump test can be extended to assess his obturator nerve. Normally we would get pain medial and inner border of his thigh, and to assess his obturator nerve we would put the patient into the slump test position again, if we can just demonstrate that. But we would also abduct his hip, and doing that procedure will elicit pain if the test is positive. So if he has an obturator nerve problem, then that would be positive there. Next, I would like to demonstrate the femoral stretch test. The femoral stretch test will tell us if we have a lesion, a disc problem at L2 to L4. And the way that we do this is we get the patient to lie on his tummy, so prone. Can you lie down there for me, please? And with a femoral stress test, what we're doing is we'll flex the knee and then we'll extend the hip. If it is a positive test indicating a lesion at those areas, then we will expect to get some discomfort, pain over his anterior thigh. Okay, so I'm just going to demonstrate the femoral stretch test. I'm just going to bend your knee. Okay, so we bend his knee to 90 degrees, and then we would apply some pressure and extend his hip, and any pain, no pain elicited, that's fine. Okay, thank you. So that was the femoral stretch test. If we were worried again about a lower back problem, we could do a Faber's test, which we've demonstrated in a previous video, but I'll quickly show you how I do a Faber's test. Could we get you to lie on your back, please? So a Faber's test refers to the position of the hip joint. So we flex the hip joint, we abduct the hip joint, and we externally rotate. If the test is positive, we may elicit lower back pain. So to do that, we flex, abduct, and externally rotate. Okay, and that will tell us whether or not we have any. That's called the Faber's test. If we are concerned about a herniated disc, we could also do a Trendelenburg test. Could we get you to stand up, please? And we ask the patient to stand, and I'm sure we've all done Trendelenburg tests before. The patient is now symmetrical. What we would ask the patient to do is to raise his leg, and if we could just get you to raise one leg up for me. This tests gluteus medius, and if there is a weakness in gluteus medius, rather than see the pelvis tilt upwards on the side of the leg that's being raised, we would see the pelvis tilt down, and that may indicate that he does have a herniated disc. Another test that we can do, finally, the final test would be a Thomas's test if we were worried about an anterior pelvic tilt. And again, we've demonstrated a Thomas's test in the past. Basically, what we would do with the Thomas's test, can we get you to lie on your back again, please? Okay, so a Thomas's test is really to look at a fixed flexion deformity at the hip joint. And the way that we do it, can we get you to bend this leg up and just hold that up with your legs as far as you can. For a Thomas's test, if the test was positive, then we would see this leg would raise up as the hip was flexed, but that may indicate that he has an anterior pelvic tilt, so that's fine. It measures iliopsoas. That's good. Right, so we've gone through our special tests that we've done. Next we move on to the neurological examination, which involves checking his motor, his sensation, and finally we do the reflex test as well. Now, to assess his motor function, if I want to assess L1, 2 or 3, I would normally check his hip flexion. So we get him to bend his leg up. If we get you to bend your leg up and just bend your knee as well if you can. Now what I want you to do is I want you to keep this leg up, and I'm going to try and pull it down. This is testing for iliopsoas muscle. Let me just, you resist me. And there is no weakness there, but a weakness there may indicate an L1, 2 or 3 lesion. Secondly, if we wanted to test for L4, we would, with his foot in this position, we would get him to kick his leg out, so basically straighten his leg. Can we get you to move your leg out? Okay, that's fine. And so that feels as though his muscle strength is completely normal. If we were testing for L5, if we just get you to straighten your leg, what we would look for is basically his extensor hallucis longus, which works his big toe, flexes his big toe, extends his big toe. And we would get him just to extend your big toe up towards you. And if we're looking for any problem in extensor hallucis longus, it may indicate an L5 lesion. Just resist me, just try and keep this up. And we see that that's normal. And finally, to test for any S1 lesion, we get the patient in this position just to press down as hard as he can, and that's fine, and the power is good. We'd also do a straight leg raise test, and again this normally indicates any problems with your sciatic nerve or with any disc herniation. And the way that we to do a straight leg raise, what we would do, or Lassagne sign, we'd get the patient to keep the leg straight. We'd normally lift it between 30 and 60 degrees. A herniated disc would usually produce some pain, normally in his lower back, radiating down his leg. And if we wanted to extend the stretch, then we can dorsiflex the foot, and that may elicit a positive sign there. Okay, that's fine. Now, following that, we move on to sensation. The way that we test sensation is with a monofilament. And the way that we do this is that we would get, normally we would test for, if we think about L1 is in the groin area, so we'd normally test there for any lesion there. Can you feel that? Okay. L2 comes across the anterior thigh. L3 is around the knee area. L4 is on the outside of his foot, of his leg. Any problems there? Can you, no, sensation normal? L5 is normally between his first and second toe, so we'd normally test that. and S1 is on the outside of his foot. So is that normal sensation? Yeah. Okay, and we can do that. We can do it with a monofilament. We can do it with sharp as well if we wanted to assess that. Following that, then we move on to his reflexes, and the main reflexes that we're concerned about are his knee and his ankle, and I will demonstrate how I would check his knee and ankle. Okay, if we just relax for me, if you don't mind. Now, to test L3-4, we would test his knee. I'd normally have his knee in this position, and then we'd hit the patellar tendon, and as we see, there is a reflex. If we wanted to potentiate the effect of the reflex, we can get the patient just to pull their hands apart as we do the test. Right, would you mind pulling? There we are, and the reflex is present. That's L3-4. The way that I test the ankle jerk is I would get him just to bend his knee, just relax in this position. We would dorsiflex his foot, and then we would do hit the Achilles tendon, and as we see, we've got a good reflex there. If we wanted to test L5, we can do the hamstring reflex, which is basically, to do that we would squeeze across his knee, and then we would apply, just with a slight bend in his knee, we'd apply a little we would see that test for L5 if we have a positive hamstring response. Finally, we would test for other signs of upper motor neuron lesions. We would do a Babinski, which should be flexor. To do a Babinski response, we would draw our patellar hammer up the side of his foot, and as we see flexion in his big toe. If there was an abnormality, an upper motor neuron lesion, we'd expect to get some extension. Finally, we would test for clonus, and to test for clonus, we do this at his foot. Again, this may indicate that we have an upper motor neuron lesion, and to do this, we would dorsiflex his foot very quickly, and normally a positive clonus, we'd expect a lot of jerking as we do that, but that is fine. That concludes my examination of the lumbar spine. Thank you.